Collaboration is essential to ensuring patient access to medical innovation. I think first of all, it helps to define in a meaningful way what innovation is. Innovation isn't just something new. It's something that solves a problem. It's something that makes a difference. We can't get to true innovation without collaboration, without involving clinicians, researchers, hospital administrators, and a host of different stakeholders, those who develop the therapies from industry, as well as the patient. And I think sometimes, until recently, more often, the patient is left out of that collaboration equation, if you will. But really, if the patient hasn't been working with all the other stakeholders to define what the problem is, it's impossible to have innovation.
Hello. Oh, is this on? Okay. Before I tell you who I am, I'm just going to tell you that our Twitter hashtag is patient value, hashtag patient value. We have a Twitter wall over here. And I wanted to thank you all for coming and being here with us this evening. I know we know that SABCS officially starts at 7 o'clock, so we're working really hard to make sure that we're done before then so everybody can get over there. Good evening. I'm Terry Wilcox, the Executive Director of Patients Rising. Welcome to San Antonio and to Texas, which is my home state, and the one and only Alamo. This is our gathering that we call Voices of Value. We've turned up the volume on Voices of Value from one end of the country to the other and everywhere in between. And no matter if it was in Chicago or San Francisco, St. Louis or San Diego, Southern California or Boston, Massachusetts, the patient voice, the permanent voice came through loud and clear. But we aren't just here to talk. We need to listen and learn, take action and take charge. Patients Rising has a fundamental cause: to stand up for patients, to advocate for their rights, to fight for the access to the treatments that they need, and to tell the truth about healthcare. And one of the truths we must tell is that change isn't just coming to healthcare, it's already here. And according to a recent report, alternative payment model use increased by 6% from 2015 to 2016. That was a 23 to 29% jump, and that 6% is no small number. Now, fee-for-service, for those of you who understand that, no, it still dominates. But as insurance companies rely more on value assessment tools for what treatments will be covered, what services will be paid for, patients living with chronic and life-threatening illnesses need to be hyper-vigilant about their coverage, claims, and especially collaboration. And that has brought us here, the Alamo. Our program tonight is Collaboration, the key to ensuring patient access to medical innovation. And it was made possible by some of the very best collaborators we know: Amgen, Bristol-Myers Squibb, and Celgene. Please join us in thanking them. Now, what do we mean by collaboration as a key to ensuring patient access to innovation? We will explore it in three ways: the most important topics affecting patient access to the latest medical innovations, exploring the ways these topics can best help patients and caregivers, and how all facets of the industry can work together to unleash new approaches to enhance patient value and extend medical access. Patients Rising sums it up this way: it all comes down to access, innovation, and reform, AIR. And that's appropriate, as I now have the honor to introduce you to our moderator, who we think is a breath of fresh air to these important programs. Her name is Stacey Gualandi, and you are in for a real treat. Stacey's career began with her first big scoop out of college, picking up horse manure on a movie set. That eventually led to a career in Hollywood as a host, producer, reporter for shows like Extra and Inside Edition, and a live breaking news story earned her an Emmy in Las Vegas. She's a freelance producer for several TV shows, Deluxe Version magazine, contributing editor of LifeScript, and a correspondent, and a host of the Women's Eye radio show podcast. Stacey has long been involved in issues of healthcare, starting back with us, producing a series a decade ago now called Understanding Cancer in 2007. Please welcome our friend and our host, Stacey Gualandi. Thank you.
scared when I get on a stage because a year ago I fell off one and broke 4 ribs. So I won't be doing that today. But thanks, Terry. I'm so grateful to be a part of this tonight and be able to work with Patients Rising and to be even sort of remotely involved with the Breast Cancer Symposium. I feel it's quite an honor, and I've never been to San Antonio, never been to the Alamo, so I'm no longer an Alamo virgin. And I think after this I actually might go, I found a basement underneath the gift shop, so I think I might go find Pee-wee's bicycle. So, but again, 10 years ago, yes, I got to work with both Terry and Jonathan, and the show was the project, Understanding Cancer, was very much a ground-breaking type of project. It was a website, it was a TV pilot, so it was a really wonderful opportunity to get to learn about cancer, treatment, all the ins and outs, because at the time, it helped me tremendously because my father was dealing with and losing his battle with prostate cancer, so it was very helpful for me in terms of navigating, but it still remains, this whole concept is extremely complicated, as we all know. Now, as a TV reporter and a radio host, I really do get to learn a little bit about a lot of things, and today is really no exception to that. I think it's an understatement when we say that the economics of healthcare is really, it's like a maze surrounded by multiple layers of twists and turns, and it's very overwhelming, especially for patients and caregivers. And even though I was a caregiver for a short period of time with my dad, I feel that this is something that I'm going to be learning right along with you today as I interview our expert panel, and I'm really hoping my mission today is to be able to have answers to all of your questions. Again, with our expert panel, we have a patient navigator, a policy expert, we have also a safety net network provider, as well as a cancer survivor who's going to share her personal, we have 2 cancer survivors sharing their personal journeys as well. So, but before, I want to make sure, yep, we do have another video. So, but before I introduce our first guest, I want to have you watch just yet another video with Donna, who is the president and CEO of Global Liver Institute. Take a look.
Patients have the ultimate stake in policy conversations. Our lives are at stake. So one of the roles that I have, I think one of the most important roles that I have as a leader of a patient advocacy organization, is redefining what policy options, what policy levers are available for patients. Often we think just in terms of federal or legislative policy, but as I know, having lived in Washington for, I'll admit it, a quarter of a century now, is that regulatory policy, reimbursement policy are often the things that are make and break for patients and for truly determining what access to care means. So I'm very optimistic about the policy-making process because I see the role of patients opening up and developing in a very positive way. I think that the biggest stumbling block, if you will, to the full realization of patients and patient advocates in policy making is just our own learning curve. And as I work to help make sure that patients are educated and equipped to contribute meaningfully to all the different forms of policy, as well as just being aware that these opportunities exist. That's where I spend the most of my time, and I think that's where there's a lot of opportunity to grow.
And without further ado, I get to introduce our first guest. It's Marjorie Gallece. Rhymes with police.
Yes.
I remember you telling me.
How we tell it.
Patient navigator with the Breast Cancer Resource Center. How are you?
Fine, thank you.
Great. But first, you are not only a patient navigator, you are a cancer survivor of over 15?
17, going on 18 years.
Woohoo!
So far.
I know. So, I mean, cancer really infiltrated your family, did it not?
Very much so. I grew up learning, really at the age of 16, how to advocate. My mother was a nurse, my dad was a veterinarian. And my dad started showing symptoms of what the doctors thought were Rocky Mountain spotted fever, and it was actually Hodgkin's. It took us about 10 months to get the correct diagnosis. I lived in Connecticut. We ended up going into Memorial Sloan Kettering. My mother advocated, and I learned a very early, sad lesson on how important it is to get the diagnosis right and get it in a timely manner. Now, granted, that was in the early 70s. It was a lot different then. Oncologist was pretty much a new term. And so I did lose my father to Hodgkin's. And then many years later, my mother developed breast cancer. And she went into a clinical trial at UConn with iridium seed implants. Mm-hmm. And she was not going to do chemotherapy. Would not. And she survived that. And then 15 years later developed pancreatic cancer. The year she died was the year they announced the BRCA mutations. Yeah. And that was my first clue that
something's up.
She was raised in an orphanage, but we didn't know a little bit about there was Eastern European lineage and all. So when I got my diagnosis at the age of 45, which, oh, by the way, I had to fight for,
yes,
in that imaging.
Because of your age, yeah.
Well, partly that, and the imaging, sometimes captures things and sometimes doesn't. And I had two kinds. I had both lobular and invasive ductal carcinoma. But I knew the hallmarks of cancer. I had gone to the School of Hard Knocks, so I knew that losing weight for no reason, having drenching night sweats, getting sick at the drop of a hat when someone across the room has sneezed, all of those things that I went, okay, my immune system's screaming uncle. So I did what I could. The imaging never did show the cancer. And I ended up feeling the lump.
Again, being your own best advocate.
Right,
yeah.
right. My husband thought I was nuts every night in bed, arm above the head, feeling that breast, doing it like a clinician would. And I found that lump. And had I not, we wouldn't be having this conversation probably, because I did have no clear margins on this side. I did insist on the bilateral mastectomy and went through treatment. I had 3 positive nodes, another tumor growing off of one of those. It was estrogen and progesterone negative, HER2 positive. And at that time, there was a clinical trial for Herceptin, which my insurance company said, we won't cover any of your routine care costs if you go into that clinical trial. And I couldn't afford all my own scans and blood tests and all. And I had really great insurance. So that, again, made me put on my advocacy hat.
Yeah. It's interesting because we're going to hear from a cancer survivor as well who says that, what's great is if you have a Marjorie. So it's like everybody has an advantage if they have someone like yourself. So do you feel like your journey, your experience helped inform you to be a better navigator for other patients?
Oh, absolutely. I wear several hats. Now, with the Breast Cancer Resource Center, I am a patient navigator, but I got science training too. So I sit in on grant reviews as a patient
to get that money,
advocate.
Right? Yeah.
Well, also for research, like with the California Breast Cancer Research Program, I am an out-of-state reviewer. But I went through my training with the National Breast Cancer Coalition. I made a lot of good friends, and I was mentored by some wonderful advocates who, sadly, many of them are no longer with us. That's the hardest part of this world. We do lose a lot of people. The good news is we're all living longer after we've been diagnosed. There are wonderful treatments out there. The bad news is this is a highly recurring disease. We learn 20 years out, 18 years out, there are some people, not all people, but some people who will have recurrences or metastatic recurrences.
Right.
And that's frightening. That's a lot of my navigation is trying to help people get past that terrible fear of recurrence once they're finished with their treatment.
For you, because obviously you're certified.
Certifiable.
Certifiable.
Some would say, yeah.
After what
No, I
you've been
am
through,
certified. I just sat
don't
for
blame
another.
you.
I just sat for another test that I hope I passed. We'll see.
See, so it's something that even this many years, 17 years later, that you still have, you are on top of it, obviously, but it's still something that's always there.
Yes.
What do you think I know when we spoke, you said you know how to get people what they need without the costs. Is that just, do
Well,
you feel
some
like it's
without
getting
the
better?
costs. It's
Okay.
expensive. It's becoming less and less accessible. The funds are drying up.
Is that the biggest problem, really?
That's one
is
of the biggest,
accessibility?
the
Yeah.
accessibility, and not everybody qualifies. You could have insurance and not qualify for a lot of things because you have insurance, even though you have incredibly lousy insurance. Nobody understands that it's for the unthinkable. Nobody knows if they've never been sick that they should know what's in a formulary. And if oral cancer therapies, we fought very, very hard for parity in coverage for that. I helped draft that bill for the state of Texas, and we fought very, very hard with some of the ladies from the Alamo Breast Cancer Foundation. We went up and, a lot of different things. Routine care costs for clinical trials. I encourage a lot of our stage 4 ladies, but you don't have to be stage 4 to participate in a clinical trial. I educate a lot about that, to take the fear out of it, because everyone thinks it's just whole-scale experimentation. Until you're faced with this, you don't understand that the fear drives a lot of decisions. And one of the first things I tell my clients is fear is a terrible decision maker. Our goal, especially at the Breast Cancer Resource Center, is to make people informed and empowered decision makers along with their medical team.
I mean, obviously that's where you want to guide them through that, because so often they are overwhelmed. They can't, you have to have a team around you, and that's what you're holding the hand as they're going through this too. But what do you see in terms of perhaps even Texas and right now, what's happening? Do you feel that we are on the precipice of something fantastic when it comes to providing value and the right care?
What I think, and I hope I don't get in trouble for saying this, what I think is that there are some wonderful treatments out there that people are being barred from being able to access for whatever reasons. Financial obviously is one, insurance is another, and then that whole first to fail business that we go through, the step therapies, and you've got to go through all these different toxic type of therapies before you can get to the thing we know is probably a lot better. The clinical trials are out there, they get approved, and yet oncologists are forced to have to give their clients something that was really great 10 years ago, but today there's something much less toxic that may do the same job. And getting that approved, trying to get the access to that is very difficult for many people.
Do you see, no two patients are the same.
You're right.
Because there's probably nobody that's had the same path that you had. How important is it for the patient to really play an important role in their care? Do you know what I'm saying?
It's absolutely key. One of the first things we tell people is you are the head of your medical team.
You're the CEO.
You are. And I have my whole restaurant type. I'd say if someone came to you with a menu and all it had was the name of it, of what it was they were going to serve you, but it didn't tell you how it was prepared, what the cost was, what the spices were in it, any of that, what would you tell that waiter? Well, why would you do anything less with your body? Why would you not be even more mindful, study up a little more on it? And it's very hard when you're in a state of shock. When you get this diagnosis, the air goes out of the room, the floor just falls out from under you. And so often I'm in the room when people get that news. I'll take notes, I'll type them up, I'll try to explain it, because you can sit there and the doctors explain things beautifully, very clearly, but you walk out of there and you go, huh? I know, I was just explained, but it's very hard to take in all that information. It's information overload, and then you're asked to make decisions. And it's like cramming for a graduate level exam for a course you never took.
Is there a success story, because we're kind of wrapping up here, is there a success story that you see in terms of, we hear a lot about payment models and those kinds of things. Do you feel like there is something that's kind of, a potential success story for patients?
Well, what can be wonderful is when a woman comes to us and she actually qualifies for, say, the breast and cervical cancer program, but didn't know anything about it. It's amazing how many general practitioners have no clue about those programs because they don't work on getting people into them. But when someone comes to us, the first thing we do is say, okay, if you're not insured, what is your income? How many people in your household and all? And then we immediately see if they can qualify for some of the federal programs. And there was a time in Texas, again, when we had screening and no treatment follow-up to that program. And we held the governor's arm behind his back in an election year and said, guess what? We're going to go public with this, that you're out there screening women and sending them home with a diagnosis and no treatment arm. And so Texas very quickly got on board with that.
That's good.
So,
That's good.
you know, and that's advocacy at its best.
Yeah. Just as we wrap up here, is there one thing you want patients to know? I know you said something to me, you know, when we spoke, but what is it that you want patients to know?
That there's help out there,
Mm-hmm.
that there are people there to help you. Ask for it, look for it, don't be shy, that you are your own best advocate. Our goal is to empower people to know that the help is there.
Mm-hmm.
You just don't know it's there until you need it.
Yeah, that's great. Is there anything we forgot that you want to make a point to include?
I
don't want to forget anything.
I don't know. But I think one of the things, and it was based on that film, is that we forget how important patients are to moving the science forward. Clinical trials are why I'm alive today. Somebody entered a clinical trial and tested the drugs that made me the survivor I am today.
Yeah.
And I am forever beholden to those faceless, nameless people.
That's great. Sheila, thank you so much for your time. I really appreciate this so much. Sheila, did I just call you Sheila?
call
Because I'm
me
looking
Sheila.
at Sheila.
It's
So
okay. It's
Marjorie
all right.
Gallece.
We can be interchangeable.
I know.
It's okay.
But Marjorie, thank you so much for taking the time to. And again, it's the Breast Cancer Resource Center. I really appreciate your time.
Thank you.
Thank you.
Bye-bye.
So, I knew I was going to do that. So, thank you. Awesome. What's that?
It's okay to get down now, right?
Yes, you can. And I think we have our next video as well, again from.
Value, as it's now talked about in healthcare, is often very disconnected from the patient world, the patient advocacy community, and we need to change that. And I think often people try to oversimplify value. They think that we can come to just, one score or one number or one definition of value. Well, if there's going to be just one definition of value, it should be mine as the patient. But I'm willing to submit that we can talk about a few different ways to think about it, but those need to be very transparent and those need to be very clear at what level we're talking about in the individual, population, or national societal level. One of the things that patients and patient advocates need to watch out for when they're working in the value field or value assessment field is what's called a QALY, or Quality Adjusted Life Year. It's based on the premise of the perfectly healthy person, which means that as a patient, you're automatically less. You're going to be less every time. And God forbid you have multiple conditions, because then you'll be what's worth less than less. I'm not an economist, but I don't think it turns out to our advantage. So certainly for someone like me, perhaps like you, living with multiple conditions, it may never come out worthwhile on a mathematical formula to treat us for anything, because according to equality, we're just not worth it. How can we ever win? So equality is something that I think is particularly pernicious in the value framework world, and as CMS and Veterans Affairs and others threaten to use this as part of their calculations, I think patient advocates need to be upfront in saying no, saying this is not how you measure our value as people, as citizens, as family members, as members of the community, as contributing members of society. We just need to say no to the quality. So value for an individual is very personal, and the mathematicians often say, well, it's impossible to integrate into any workable formula. So as a patient advocate, it's our responsibility to help present those individual preferences in a way that can be incorporated into various assessment tools.
Well, our next guest is Dr. Merrill Matthews, who is a resident scholar at the Institute for Policy Innovation. So that is a mouthful, right? Hello there, doctor. How are you? Thank you. I think you probably wear many hats, though, right? That's just
I do,
one.
but only one pair of boots.
Oh, I didn't even notice the boots.
You're in Texas now.
Yeah. Somebody told me some good advice once. They said, what did they, don't wear your, what are they called on the back of the spurs? Yeah, don't squat with your spurs on. I don't know. We'll leave that for another day.
Well, Dick Armey used to say, we don't polish our boots often, but we never polish anybody else's boots.
I know, it's good. It's probably safer that way. So, but thank you for being here too, because obviously this is a passion. This is your job is to understand policy, not just it relates to here in San Antonio. It's kind of across the board, across the country. But it was interesting in listening to the video too, because when we spoke too, you talked about do patients have interest in value? Do you think that comes into play for a patient?
They do have an interest in value. Historically, though, I don't think they've been very value conscious, or at least even that concerned about it. Historically, patients in the U.S., if they went to the doctor, they went to the hospital, they went to the pharmacy, somebody else was paying the bill, and so they didn't often sort of look at the things that we would think a consumer would normally look at. That's been changing. You've had a sort of a consumer-driven healthcare movement that's been going for the last 10 or 15 years and expanding now, and consumers are increasingly going on the internet, going to material and other things, and they're coming to the doctor
they're
filled
shopping
with,
around,
they're shopping around, they're coming to the doctor with information, and they're asking doctors important questions that they didn't used to do.
So that's a good sign.
I think
right?
that's absolutely a good sign, because one of the debates has been whether or not individuals can be consumers in the healthcare marketplace. I've argued for years they can, but there's a lot of people on the other opposite policy side who just don't believe they can be, so they feel somebody else has to make those decisions for them, and I think that's exactly the wrong way to go.
Why? Do you
what you'll hear is they'll say healthcare is different. So that, yes, people can be consumers when they're going to the grocery stores or they're buying a car, but they just can't make good health care decisions. And I think that's absolutely wrong. In the years past, they didn't have that much access to information. Now they do have access to information. There's more and more patient support groups and other things out there which really help patients become informed and able to ask the right questions.
So they have access to more information, but is that helping in terms of just access to good, valuable care?
I think it is, because they're raising questions with some of their doctors. And of course, these days, you have, one of the things that have changed is now the vast majority of Americans have insurance. They passed a prescription drug benefit in Medicare in 2003. The Affordable Care Act has a prescription drug benefit, so now roughly 90% of the population has a prescription drug benefit. Some of it is not as good as others, but you do have the vast majority that do. However, one of the things I think is changing now is I think insurers are increasingly looking for ways to discourage patients, especially high-cost patients, and by that we mean high drug-cost patients, from coming to their various plans. And there's ways they do that by raising the deductible, raising a copay, making it very difficult. In some cases, if you're going to use this drug, we're going to raise the copay significantly as a sort of subtle way to say, if you want to shift to another insurer, that's okay, because we don't want to care for you. We don't want to provide that care, and that increases the out-of-pocket costs for a lot of them.
So, okay, so a patient then, what kind of, do they have in their bag of tricks, I guess, in order to try to combat that?
I don't know that patients have a lot. They're faced with, in some cases, some high expenses. The drug industry is looking for various ways to try to address that need. One of them is this thing called value-based medicine, where they're looking for ways, they're trying new models. And one of them might be to say, we've got a very costly medicine here. We don't know if it's going to work or how well it will work, so we're going to make a deal. We'll provide this for the patient. If this works well and meets certain benchmarks, the patient or the insurer is going to pay for it. If it doesn't, they'll either pay less or won't pay anything at all. And that's a kind of a new model we've seen out here that's every drug company is interested in it. They're exploring it. It's a work in progress right now. We've made some progress on it. Not all drugs are going to be suitable for that. Not all companies will be able to move into that direction. but it's a new way to where you try to you make sure that patients are getting value for the dollars that are being spent.
So is that the same as the alternative payment models? Is that something kind of separate from that?
That is one of the alternative payment models that's being considered right now, and is already sort of taking effect to some extent. Like I said, it's a work in progress, but we may see a lot of developments come about with that in the next few years.
With alternative payment models, what do we actually mean when we say that? Is it pretty obvious?
We mean something that looks apart from the standard insurance model. And so, for instance, Dr. Scott Gottlieb, administrator of the Food and Drug Administration, FDA. Prior to being named to the head of the FDA, he had proposed people being able to find long-term financing for prescription drugs. It's one of the models that are out there. He said, you could do this, you could finance this over years as you might a car or a house or something like that. I've proposed something a little less costly out there. There's about 20 million people with what we call a health savings account. They've got about $40 billion in those accounts right now. It's still a fairly small part of the market, but in many cases, this health savings account is connected through a bank. And so I would suggest that we might look at a model where if you're hit with major drug costs and maybe you're going to exhaust your HSA, you might be able to go to a short-term financing, like small businesses sometimes have a line of credit with the bank they're working with, so that the bank could step up and say, we see it's going to cost you more than what you have in your HSA. We'll put in a line of credit here that in the future we'll let you pay that back as you make deposits to your HSA. That would work for things. If it's going to be a chronic situation, wouldn't work as well, but it might if you need something for a short period of time.
Exactly. Because everyone kind of understands how the banking situation works, but maybe they don't necessarily know how insurance works.
Right.
Because, that gets a little nutty, I think, at times too. But and so specifically regarding prescription drugs, because you talk about a long-term financing. Outcomes-based was another one that you mentioned.
Outcomes-based, that's what we were talking about with the value, because essentially they're saying, we're going to provide this and we'll set some kind of metric for an outcome. Now that can vary. Does it mean years of extra life? Does it mean cancer-free? What does it mean? So that will have to be determined by the drug and the disease. So I don't think there's going to be one model for all, but there may be various types of models out there that allow them to do that.
Great, and also you talked about short-term too as well.
Short-term financing, right.
This was also interesting too, is the sort of that nonprofit where you can always, we've all seen those GoFundMe pages.
Exactly. I find this interesting. I watch the news at night. Occasionally they have someone on the news who has been in an accident, a major medical condition. Sometimes they have insurance, sometimes they don't. And they're bringing that person there, and that person's is in the hospital. They're getting care. They talk about how costly this is going to be, and at the end of the newscast, they say that we've set up a GoFundMe page on our news station website. If you want to go there, and they'll come back
total strangers.
Total strangers. 2 or 3 days later, they come back maybe with a follow-up, and they say, incidentally, people have donated $30,000, $40,000, $50,000 to this, and nobody ever asks the question, is the hospital charging too much? Should the patient have been insured? Or those kinds of questions. You feel good about the fact that people have stepped in and made these contributions to help somebody out, because you're just helping someone out. And so it struck me that if some of the disease groups, patient advocacy groups, were to set up a nonprofit thing, GoFundMe kind of deal, here's Mary over here who has this problem. We're going to let everybody know about it and see if people can come in. They may chip in $10, $20, maybe $100. Who knows? For many of them, they may not even deduct expenses, so it may just not be a tax write-off for them. But I think we would see a lot of people get some help from people if it's made available for them in an easy way.
Interesting. I'm sure you hear a lot of voices from all different specters or all different pockets and all these silos and things like that as people talk about it. But what is the one thing that we really need to overcome, do you think, in terms of attitudes or in terms of getting to that place of collaboration?
We've got we're moving to an area where drug companies, the cost of research is increasing, but the target populations are increasingly shrinking.
Okay.
So if you're looking in the 90s, they were making small molecule pills that might go to 2, 3, 5 million, 10 million people. Now they're targeting these rare diseases, defined as 200,000 or less, but it may be 20, 30, 40,000. If you take the same drug cost and you try to divide that over a population of 20 or 30,000, it's going to be an awful lot. So the question is of cost.
Yeah. Mm-hmm.
How are you going to find a way to make sure that people can address these? One of the things I thought was there's a completely different insurance model out there where we use life insurance.
I love this because you kind of described it like car insurance.
Right. In life insurance, life insurance, if you get a term life insurance policy, there's only two things that can happen, and both of them are bad. You either spend 10 or 20 years paying for it and you don't get any benefit, or worse, you get the benefit of it because you passed away. But a lot of the life insurance companies actually have what they call an accelerated benefit or critical care component. So that if you have this term life insurance policy and you need major medical care, you have high prescription drug cost, major surgery, and your insurance isn't going to cover it all, or it doesn't cover any of it, the life insurance company writes you a check. It will lower the benefit that you're getting from it. So if you had a $500,000 policy, it might be a $250,000 policy, and they'll write you a check for several thousand, in the hundreds of thousands of dollars. It may, as I said, reduce your benefit, or it may eliminate the benefit, but you have a check in hand to be able to go out and help pay for these high costs. Now, there have been companies around that do things like that for years. The Aflac kind of model, you get cancer and they give you a $50,000 check or something. But the life insurance option gives you a whole different option. It can provide you with a lot of funds, and if you never need it, you still have the life insurance benefit if you need that at some point.
Is that hasn't been around for very long?
Oh, it's been around for a while.
Okay,
It's just most people don't know about it, have never used it. I've written about it a couple of times in Forbes, but it is an option that's out there, and as people need more funding out there, it may become a more viable option if people learn about it.
Again, because it's getting the word out there. I mean, I think that's the primary.
When I tell people about this, I've never even heard of anything like that, but it's been around for years and people use it.
So, doctor, if you were in charge of the country, what would you like to see? Where do you feel we're doing good and where we're doing bad, and maybe where we're status quo?
We need to move to a consumer-driven healthcare system in which patients are looking for value for their healthcare dollars. We were moving in that direction. The Affordable Care Act sort of changed that calculus a little bit. We had typically said you ought to have a high deductible policy and a health savings account. A lot of people have high deductible policies now, much higher than I would have ever recommended. They're going $6,000 or $7,000.
High deductible.
Yeah. But you want to combine that with a health savings account. I wouldn't even have the insurance as part of it, just the health savings account where employers or individuals can make tax-free contributions, or anybody else. So that for the smaller and routine care, you're paying for it with this and you're asking the doctor, where do I get value for my health care dollar? But you have insurance there that's good insurance that steps in and covers the needs for the very high cost accidents and illnesses. So that's where I think we need to go. We've kind of taken a sidestep with the Affordable Care Act, but because policies are getting very expensive and the deductibles are going up so high there, you might be able to get back on the right path at some point.
Interesting. Yeah, it's very complicated. I mean, for you, what is the most frustrating thing for you? Because you've been doing this for how long?
25 years.
I was going to say 2-3 years. No, it's 25. So yeah.
Most frustrating thing about me is most people don't understand health insurance or the healthcare system, and those who understand it even less tend to be the politicians who pass laws that they impose upon the rest of us.
They're all doing okay with their insurance.
They're doing okay. If they're congressmen, they have the Federal Employee Health Benefits Program. So they oftentimes don't know what they're doing when they're passing the laws, but they think they do, and they create all kinds of problems and disincentives and so forth that shuffle the system, and it's not working nearly as well as they would have liked it to do, or they thought they would be able to do it. But if you can get patients in charge, especially if patients can control the money, I think we'll get back to the right type of system.
Fantastic. So is there anything that I have forgotten that you would like to express in terms of the patient and making sure to ensure their value?
It is a very complicated system.
Yeah.
And it's getting more complicated rather than less complicated.
See, that's really, okay.
But the good news is patients are increasingly going and trying to become good, inform themselves about their options and what they can do, and they're taking that knowledge into the healthcare system. In years past, the doctor was the center of it. Everything circled around the doctor. Increasingly, the patient's becoming the center of it, and everything circles around the patient, and that's the kind of system we want.
That's a good trend, right?
It's a good trend.
Fantastic. Well, Dr. Merrill Matthews, aren't you glad I didn't call him Sheila? But thank you so much for your time and insight and expertise. I really appreciate it.
Thank
so
you.
Much. So thank you. Keep writing those papers. So thank you so much.
Alternative payment models are mentioned frequently these days in policy circle. APMs, MACRA, MIPS, there are lots of acronyms, but basically what patients need to understand is what these are alternatives to. They're alternatives to having the healthcare system being paid based on the number of procedures that are performed on us, and instead thinking of an alternative, thinking of a different way to pay for medicine, to pay for healthcare, and that's based on, I think, thinking of us as a whole person. So if a healthcare system or a clinical practice gets one price to treat a patient through their cancer therapy or through another type of episode of care, we would need to make sure as patients that we are watchful, that it is not just an opportunity to reduce the amount of care that's provided, but that it's really a way to provide patients and their families with the best care, the fullest care that they need to be healthy. Payment models need to be pro-patient, if you will. Often they're called patient-centered. A friend of mine termed an excellent coin of phrase. She says that many of these initiatives are merely patient-centered instead of patient-centered. So I think it is the obligation of patients and patient advocates to learn about alternative payment models, to draw in those of us who have economic backgrounds, quality improvement backgrounds. You know, just because you're a patient or diagnosed with a disease, they don't take all your degrees away, which is what many people think. And so there's an incredible amount of expertise that we can bring to bear, both from just living with the condition as well as all the things that we bring to the table to make sure that whether you call it bundled payment models, alternative payment models, oncology, medical homes, that they're really informed by what patients need the most and what patients think about how care should be delivered.
Well, our next wonderful guest is Ayanna Castro-Clark. She is the Director of Contract Management for WBHN, the Western Behavioral Health Network. Let's welcome Ayana. Hi, how are you?
Good, how are you?
Good to see you.
Likewise.
Again, yes. And talk, well, now we got like a face with a voice, so it's awesome. But so this is, you're very a little more niche, I guess, oriented in terms of the work that you do. So explain real quickly what WBHN does and who you are targeting in terms of patients.
Okay, so the Western Behavioral Health Network is made up of 6 clinics that are in West Texas, and they're the safety net providers for individuals with behavioral health needs in the state. So most of our clients have Medicaid coverage or don't have any coverage at all. And so we serve, like I said, clients that have mental health needs, including early childhood intervention, as well as those with intellectual and developmental disabilities, and substance use disorder in some senses. But most of our clients have, bipolar, schizophrenia, and those sorts of illnesses.
It's obviously very, very difficult because it's a whole, because we have people on one spectrum, and then there's the folks in the middle, and then there's the folks here that are, maybe need it more so than anybody, or need that extra assistance. For you went from policy into this area, and I think you described it as like boots on the ground.
Yes.
So what do you mean by that? Like, why is that important for what you're doing?
So I think just to echo what Merrill said is, I think, I worked for the Texas legislature for a while with the budget office, and just kind of seeing how policies were made, and it's one thing to see that, but it's another to see how they're actually implemented and if they're actually working. and then just some of the considerations that, the providers who are getting paid very little to serve these patients, and how the patients are actually being impacted by these policies. So it's pretty awesome to be, now kind of at the level where I get to see exactly how the policies impact these patients and the providers.
So where are we at with the policy impact right now as it relates to, because it's 6 clinics, west side of Texas, very much more in the rural.
Absolutely, yeah. So there's
Yeah,
definitely
the rural area.
Yeah, the hard word to describe.
Yeah,
say,
I know, but it is. It's how is that working for that particular population?
It has its kinks and challenges. It's working though. I think my role has been really, like I said, advocating for our patients and our providers. Behavioral health, particularly like in Texas with the Medicaid program, they recently, in the last 3 years, have transitioned to managed care. Before, the arrangement for paying the providers to provide these services was just kind of like fee for service, where you just provide for the state would pay directly to these providers, and so now we have an insurance company that's in the mix, which complicates things, of course. But it's also there is some benefit in terms of being able to collaborate and with the insurance companies and other providers that are serving the same patients. And so I think a lot of the challenges have been just really adjusting to this new kind of managed care environment for our providers and our patients. And so, yeah.
Is there a downside to that in any way?
Yeah, I would say I think just the challenge of the transition. It's been,
it's been one way for a certain amount of
yeah,
time, and
exactly.
then try to change.
Yeah, so it's been difficult. For example, with most insurance companies being authorized to provide a service and how that process works, and providers before were used to the state. Having a formulary and how, what they could provide and just being used to that. But then the managed care organizations have a little bit of a say too, and can sometimes advocate, but then sometimes also be a barrier to care.
In the video, you heard a lot about these alternative payment models, or all these different types, the bundles, that kind of thing, in terms of helping the patient. You were described in terms of how APMs kind of work in terms of behavioral services.
So I would say for behavioral services, and this is probably more, not even just within Texas, but I think kind of nationally, I think behavioral health is kind of in the infancy of this. I feel like a lot of the efforts have been traditionally more focused on primary care and more physical health care, not so much the mental side. So it's a pretty new initiative in terms of getting behavioral health providers and patients kind of in the mix with APMs. And so with our centers, we're seeing that more through the Medicaid program here in Texas, where they are requiring the insurance companies that are managing the care of these patients to be more accountable. So they get paid incentive payments, or they could actually get a disincentive if they are not meeting certain quality measures specific to the care for the patients. And so these managed care or insurance companies are also working with providers to improve the outcomes and improve the quality of care with some of these national measures that are specific to behavioral health.
Because obviously there's more and more of these outcome tests or that kind of thing, right? In terms
like
of
outcome measures.
And how does that translate? Like if you're getting new data all the time.
Yeah. So I just in our experience with our clinics, again, this is an infancy stage for us, but working with the managed care organizations, I think I had used an example before of like a measure that is a national measure looking at following up after hospitalization for mental illness within 7 days. And
you'd like to see that more instituted,
yeah,
right?
Exactly. And so a lot of the MCOs have that as a measure that they're trying to improve on. And so they've approached a lot of the actual providers that are providing the care, including the hospitals, and we're outpatient clinics. So making sure that there's communication between the different provider types and collaborating to improve the quality of care and making sure that we are able to follow up with that patient. And because a lot of times insurance companies, they know when a patient's authorized to come to the hospital, and we may not be aware, especially with our population that's very transient. And we may not be able to contact them. They may have different cell phone numbers, and so there's definitely challenges, with that
for the follow-up.
Yeah, exactly. Yeah. So,
one thing I want to emphasize too, just in terms of what WB I just love saying the initials, WBHN, what it does is it's providing sort of, it's like this holistic approach kind of. What are some of the services that it provides other than the guidance in terms of insurance and that kind of thing?
So it's specific to our centers, but also the other local mental health authorities in Texas. There's 39 of them, and we are 6 of them. And again, we're in West Texas. But I think a commonality between all 39 centers that are these safety net providers for individuals with behavioral health needs that can't afford care or have Medicaid coverage is really kind of a holistic approach where it's not just about giving them prescription drugs and helping them stabilize with whatever mental challenges they're having at that point, but it's also the focus is on case management. And so a lot of our centers will provide help with electric bills, or if they need to have need assistance with
it's like simple
food,
life
or
things.
Go to the food pantry and get resources that they need in order to improve their quality of life.
That's the difference. Are all of these entities communicating? Is there a lot of communication going on? Obviously with your 6 clinics,
yes.
but with the others around the state.
There is. There's an umbrella organization that advocates for all 39 centers, and we talk about best practices and different ideas, but yes, there's definitely a lot of communication between the 39 centers.
See, that's in terms of other things that you'd like to see. It's after the follow-up after hospitalization, transparency. Is that something that is happening? Is it getting better?
I would
the
say
T word, transparency.
Yeah. I think the information is out there. Mm-hmm. It's a matter of, I think, helping patients navigate the system and helping patients, even those that have the Medicaid coverage or indigent, knowing that there are, particularly with the Medicaid program, again, that my lens is pretty narrow, but just, that there are measures that the insurance companies and the providers are being graded on, per se, and being able to look up that data and decide, maybe it's a matter of, do I want this insurance coverage versus that, knowing that, this managed care organization, I keep on using insurance kind of interchangeably, mm-hmm. but knowing that their performance in this quality measure that's important to me is better than this other one.
So and that would be the key. I guess, how do you think that you add value? I mean, you've kind of talked about this too, but how do you think you've add value and accessibility?
Okay. So from with my role, which is looking specifically at the contracts with the insurance companies, is making sure, particularly in West Texas, it was very rural, and access to care is a challenge, not just for behavioral health needs, but just all needs. Mm-hmm. So one of the things, just as kind of a small example, would be making sure in our contracts that we are able to provide telemedicine. That has been a really important resource for our centers, to be able to provide that for our patients that have to sometimes travel up to 70 miles, if not more, to get to care. So it helps alleviate that travel time if we were able to provide telemedicine. And so I think that's an example of something that we advocate and negotiate for in a contract to make sure that that's covered.
Oh, fantastic! Yeah. Just as we wrap up, if you had a magic wand, what is it that you would like to see instituted here, full-time basis, and perhaps maybe lead by example across the country?
That's a good question.
I think it was you're saying that holistic.
Yeah, for sure. I think definitely the approach of looking at the whole patient, and I think integration of care is also important. Mm-hmm. Again, our focus has been on behavioral health, but there's definitely been a shift, particularly in the Medicaid program, looking at integration, and so not treating a patient in silos per se, and so making sure there's collaboration between the psychiatrist and the cardiologist, and making sure that we're communicating together and making sure that we're giving the patient the best treatment that we can.
And just one last thing, just in terms of alerting the patients and maybe calming any fears about any future concerns with Medicaid. Do you think about that? Is there strategizing going on now, if there should be any shift in terms of what happens with Medicaid?
I think really just keeping abreast of the, I think Medicaid is a constantly changing program with a lot of challenges, but I think keeping abreast, and I think advocating, whether it be on the ground level through contracts, with the insurance companies, or at the state or federal level as well.
Fantastic. Well, thank you for your time.
Thank you so
very
much.
Appreciate it. Ayana, Castro,
Yes,
Clark. So
thank you.
honey. It was very nice to meet you.
Likewise.
All right, thank you.
There is something unifying about the patient experience, no matter what disease or condition you have. Some people try to say that every one of us is a patient or will be someday. I think that lacks some really impact and some truth. The essential truth, I think, is that if you're a patient, it means that you have been frustrated by the healthcare system in some manner, that you have suffered in some unique way. And that is what starts to shape the patient experience and starts to shape really a unique view of health and of life, as well as, of course, of the healthcare system and the whole clinical enterprise. Until you've experienced that frustration in trying to navigate, in trying to save your life or that of a loved one, you haven't really been a patient. And I think for many people who've enjoyed great health, they're blessed. For those of us whose lives are really shaped by being a patient and having that patient experience, we are looking at the world through this lens of our condition and our conditions, and that lens, that experience, those lived conditions really change things for us and really shape our views and shape our voice and what we have to contribute and offer to the world.
Well, we saved Sheila, Deleon, French? No, I'm not sure. Okay. For last, welcome Sheila. We'll clap again because you are a star. You are our cancer survivor. And to look at you, you never even know that you've gone through a lot in the last 2 years. Mother of 3, and you're working. But in May of 2015, you got some very difficult news.
Yes, I was diagnosed with stage 3 invasive ductal carcinoma. And I had 2 lumps, and one was like 7 millimeters, so that was like the, and so everything started going in like super fast motion. I had doctor's appointments, sometimes 2, 3 a day. I mean, the doctors were like, we need to have you here, and here, and my head was just exploding. I didn't really get any time to even realize what was going on in my body, all that I had cancer and I was gonna die. That was the only thing that I heard.
And back and forth.
Yeah.
But also, too, with your situation, you were very, very unique. You were kind of a standalone in here in the state of Texas because it was a genetic situation for you.
Yes, I had found out. My sister had died in 2000, and she had died at age 31 of ovarian cancer, sorry. And so they said, well, we probably should do some genetic testing on you. And so they did, and I'm thinking, well, I can't have the BRCA gene. Well, no, I didn't. I have a P10 genetic mutation, which kind of nobody knew really anything about. And it makes me at a higher risk than a regular person for thyroid cancer, breast cancer, kidney cancer, melanoma, colon cancer, etc. So I have 13 doctors.
Still,
I have 13 doctors that I am being surveilled by right now. And so it kind of made that a tailspin because
well, not only are you
really
dealing with
knew.
cancer, but you've got this whole added extra layer
Right.
to the care.
And I also needed to get my children tested. And that is scary in itself. Because did I want the answer? Did I want them to have the answer? So it is. It's a question that a lot of mothers have to deal with because my oldest son, when I got diagnosed in May, was getting married in August. And so do you tell him that, yes, you're going to get married and you might be carrying this terrible gene? So I had a lot of things that I was carrying in my brain and trying to manage my care and do all that at the same time. And so I was blessed with the fact that I did get a patient navigator, and you talked to her at the beginning of the show.
You had a Marjorie.
Yeah, I had a Marjorie, and I think that that was probably the best thing that anyone can do is get support.
Because you said you had Team Sheila.
I had Team Sheila, and I had that on top of it. I had women from my church and my neighborhood that came and surprised me every day with a gift or just a "go girl go" or a flower or something like that when I was sick with chemo, when I had lost my hair, it was just incredible. I got to see the worst side of life, but I also got to see the best side of life.
Best side of humanity, yeah. How did you become, literally kind of right out of the gate, how did you become your own best advocate?
The worst, most difficult part of having cancer for me was, as you have been talking about, is the sea of deductibles and co-payments and referrals needed and fees and all the hidden things that they have.
That's what you say, like you could survive cancer, but the co-pays will kill you.
Yes.
Sick humor, but
I was scared to death of being bankrupt after this. My husband in 2014 was the recipient of a pancreas and a kidney. And so we were dealing with so many medical bills. This was the last thing that I ever wanted because my husband just received the miracle of life, and now we were faced with death again. I can't tell you how heartbreaking it was, and he cried when he got the news that I was ill and kept saying, "It should have been me, not you." And I will never forget that day. But the worst part about this was I had to balance his care and my care at the same time.
So you're a patient and a caregiver at the same time.
Exactly. Mm-hmm. So I decided one day that we had insurance. It wasn't the greatest insurance, but I wasn't going to be surprised by bills. So I decided to call before every visit, every procedure, every hospital visit. They were going to tell me what my patient amount due was. And if they didn't tell me how much it was, I called the doctor's office. And the doctor's office told me, well, we can't tell you because this is a contractor. I don't know if they're covered by your insurance or not. So we came up with another way to do it because I told him I can't do that. And for example, that person was my endocrinologist surgeon. So I ended up having 2 surgeries at once to try to save that cost. I had a hysterectomy and my thyroid removed on the same time.
It's a twofer.
It was a twofer. It was a little harder on my body, but I didn't have to pay $2,000 to some contract surgeon assistant that may or may not be paid for by my insurance.
And this is really how you managed
the whole time. I did the whole time, and I still do to this day, because sometimes it actually worked. I found out that a referral was missing, that my insurance needed a referral, and that referral hadn't come through, and I was going to get billed for the entire $600 of the cost. Or I found out that I didn't really need to have that service right away. When you're in chemo, you can't really have a hysterectomy. So all your doctors kind of decided, or all mine decided that, wow, you have this P10 thing. I want you to go see this and this and this. And they were like, you need a hysterectomy and your thyroid removed, and we're going to have a colonoscopy and all that other.
And it's just bombarded.
Oh, my gosh. And so then I found, well, no, you can't have that while you're having chemo. You can't have surgery. So maybe I could have surgery after 16 weeks of chemo.
And that's the thing, because your situation is so unique because of the genetic aspect of this. And it's made it complicated for you in terms, I mean, you've survived this, but now it's the survivorship beyond.
Which is the worst part.
Yeah, so because you're dealing with something right now.
Right. And the thing is that I'm a round peg they're trying to fit me into a square hole. And they're trying to use the common practices for cancer surveillance with me. They do not know with my PTEN genetic mutation how I'm going to get it again, or what the recurrence is, or, you know, they haven't informed me, well, we know for a fact you're going to get it in your bones, so this is where it's going to be. We know for a fact that you're going to get it. Or, you know, they just don't know. And so they're trying to surveil me and be very vigilant, and I'm getting denied.
Insurance is saying,
by
no, you
insurance.
can't have that MRI.
Right.
But you need it because you have a unique situation. It
Exactly.
wouldn't be the normal procedure, perhaps. For,
Exactly.
I mean, normal, but yeah, you know, as far as for a patient who has, you know, who has cancer as well. So what have you learned from this in terms of going forward?
I've learned I need to continue to call before each visit, whichever, and I need to know when I get denied, what is the evidence-based reason that I have been denied? Because if there's any, you know, what if I have an adverse effect? Tell me, what research says Sheila does not need an MRI to be surveilled 2 years out from her cancer diagnosis? What are you basing that on? And they told me it was because the common practice is, but I'm not the common practice. So I have written a bunch of letters, and cross your fingers, that someone will listen. And I love Marjorie. She's so wonderful. She's been
Because it's part of this whole process. It's like if there was one piece missing, you know, that you might, you know, it might not be where you are today, you know. And
Exactly.
just having all of those, and you were the master of that. You were
Yes, and it was scary, and it still is, but we're getting through it. And I didn't go bankrupt, and because I learned how to use my resources the best way I could. And still to this day, I may have to go to a different hospital. I've talked to hospitals to say, okay, tell me how much are the fees for me to be there for this procedure? And they'll say, well, it's this. And then I call another hospital and I find out, well, they're not charging for that. So I've gotten stuff moved. Because my husband's sick too. And we have to balance that. So we'll get there.
You're amazing.
No.
Unbelievable. You know, when we spoke, I asked you, you know, what advice would you have for somebody who might get diagnosed tomorrow, or somebody who is actually just recently diagnosed? What would you say to those patients moving forward?
Well, kind of like everybody else said tonight, you have to be your own health advocate. You can't just rely on the doctor to know best. You know your body best. And there were days when I felt just like crud, and I knew something was wrong, and you have to be your own advocate. And plus, you know your own health history, so they don't always know. And if you need an MRI and you know you need an MRI, you get an MRI. Don't let them go, well, maybe a year from now. No, you fight for it, you get it.
You want to do it right now.
Yes.
Be aggressively treated.
Yes.
You know?
Because I was aggressively treated with chemo, I was aggressively treated with everything else, and so why does that stop? You know, you thought it was important and now it's not anymore. So I think being your own health advocate. The other thing is be very financially proactive as much as you can. If I could go back and change things again, I would have gotten long-term and short-term disability. I did not do that. And unfortunately, I can't do that because I don't believe that that's covered under ACA. So because I had, and someone will probably have to tell me the otherwise, but based on the information I know, I can't qualify because of the fact I had cancer. So that's kind of out of the list for me. And then another thing that I would do is prioritize.
Prioritize? Mm-hmm.
And I would prioritize, you don't need a colonoscopy when you're going into chemo. You don't need to go get that dermatologist review. You don't need that. You need to ask, you know, if your doctor thinks you may have skin cancer or whatever, please, of course, go do that. But if they're just doing it because, you know, they have a checklist and they have to go off the checklist, prioritize that a little bit better. The next thing is I wouldn't let my husband drive my car. 2 weeks.
We'll find out about that later.
Yeah. Don't let him drive. But there's a lot of things that I recommend to people. And the last thing is have a Marjorie.
And have a Marjorie? No. That's great. Well, Sheila, I didn't call you Marjorie.
No, you didn't. Thank you.
Thank you so much for sharing your story, and
Thank you.
You could almost write a book, couldn't you?
That's my next thing. No.
Okay. In your spare time.
In my spare time,
so,
yes. No,
well,
thank
Sheila
you.
Deleon, thank you, and just keep fighting. Cancer picked the wrong person. When
They
it picked
did.
You. Yeah,
Thank
so,
you.
Thank you so much. Well, I just want to, that is our panel. That went so fast. I hope it was fast for you guys too. But I just want to thank you all for joining us today and really, coming along on this journey with us, and also to Patients Rising and Terry for orchestrating all of this and everybody here and making it helpful. If you want any additional information that we didn't get, that I did not get tonight, you can go to patientsrising.org. Also, panel, you're amazing, awesome. Marjorie Gallece, Dr. Merrill Matthews, Ayanna Castro Clark, Sheila Deleon, you are fantastic. Talk about collaboration tonight, right? This is what it looks like. So now I just also too hope that we helped both to empower and to educate tonight. And as I like to say, as my mother always says, to keep you happy, healthy, wealthy, and wise is what she always wants everybody to do. So before we say goodbye officially, we have one more video for you to watch. And please just take a look at the screen. And these are the voices of value. Thank you so much for joining us.
I think the patient voice is really important when it comes to legislation that's going to impact us directly.
50 of us can't show up to one congressional hearing, but if one of us can show up with 50 stories, that's powerful.
It makes sense to take into account the people who it's going to impact when you're making decisions like that.
We all have a story that is powerful in its own right. The patient voice, it makes it real.
Started my blog at the suggestion of a friend of mine, more as a method for coping through my emotions and figuring things out for myself than for anybody else. As I gained followers, I got into advocacy, and so that's another really great way to feel like I'm doing something positive about a negative situation.
As an advocate, the best part is meeting other advocates for me. The coolest part of it is getting to meet what I like to call my RA celebrities, so like the people that write the blogs, or run the foundations and things like that. They're like celebrities to me. I'm just like a pleb in this whole thing. That's a huge thing that I think a lot of patients need to hear, is that it's okay to reach out to other people, especially newly diagnosed patients. Reach out and to find these groups and to find other people that can help you along in your journey. Because you cannot do this alone.